Hello, I'm Akshay Desai, a practicing cardiologist and heart failure specialist at Brigham and Women's Hospital. And today I'm going to be talking to you about the topic of fostering patient self-management for heart failure. The overall objectives of this 30-minute segment are really to describe the self-care behaviors required of patients with heart failure, to identify the factors that make self-care challenging for patients, highlight some of the evidence-based interventions that promote self-care, and project the impact of those interventions on improving heart failure outcomes. We all know that there's been tremendous success in the deployment of effective medical therapy for heart failure, and this has translated to significant improvements over time in the measured mortality of patients following heart failure hospitalization at 30 days and beyond. That success, however, has not been replicated in the impact on readmission rates after heart failure hospitalization, which have remained largely steady in serial measurements over time or even increased. This is in part because many of the patients, once they leave the hospital, are outside the view of their immediate providers. Most days of heart failure management are blind. Patients spend the vast minority of time in front of heart failure providers in the clinic or in the device clinic. And when they are at home, they are largely responsible for their own management, including the choice of behaviors to maintain stability and the response and recognition of symptoms when they occur. The fundamental requirements for effective self-care of heart failure, like for many chronic diseases, are really adherence to treatment, including medications, dietary prescription, and the prescription of scheduled follow-up. Some strategy for self-monitoring, that is recognition of symptoms and intervention to manage those symptoms when they occur. And then a host of preventative behaviors that have benefits not only for cardiovascular disease but also for general health, including exercise, weight loss, alcohol and smoking cessation, and careful management of non-prescription medications which may interact with many of the therapies that we prescribe for our heart failure patients. We know that persistence with prescribed medications in heart failure is a real problem. If we look at 100,000 patients discharged after their first hospitalization in the country of Denmark, where there is very effective logging of prescription behaviors, we know that at 5 years, amongst patients who receive prescriptions for various medications, the rate of adherence to those prescriptions tends to fall off with time. At 5 years in this one study, published by Gisselson et al. In Circulation in 2007, 83% of patients were on statins, 79% were on ACE inhibitors and angiotensin receptor blockers, only 65% of patients were taking the prescribed beta blocker, and 56% of patients were taking spironolactone. Those patients who adhered to their therapy, not surprisingly, had much higher rates of improved outcomes than those patients who were non-adherent to therapy. If we look at the data from the CHARM study, which was a trial of candesartan in patients with heart failure across a spectrum of ejection fractions, we again see the same pattern of relationship between adherence to therapy and outcomes. Patients who took candesartan in the CHARM trial had much better outcomes than those who did not take candesartan, at least as measured by pill counts. Interestingly, in that same study, amongst patients who took placebo, the outcomes were far better than those who were measured to be non-adherent to placebo. This data really suggests that adherence is a marker not only for medication taking, but also for other beneficial self-care behaviors that may have importance in improving outcomes in the heart failure population. So why don't patients with heart failure take their medications? There are a large number of reasons that have been identified, one of which is related to the growing cost of the large number of medication prescriptions that most of our patients have. There's also a large pill burden, and as we develop the evidence base for pharmacologic therapy in heart failure, that pill burden only increases. And it's not merely the pill burden to manage heart failure, but really the pill burden that is increased by the burden of comorbidities that many patients have. Patients come into the hospital and are given new prescriptions for medications that are changed during the hospital stay, and when they leave, they then often have multiple prescriptions that may have conflicting doses, and this confuses the actual dose regimen that they should be taking. There are frequent medication changes both in the clinic and in the hospital, and by multiple providers that sometimes confound their ability to understand exactly what they should be doing. This combination of medications produces a range of side effects that make patients unwilling to take their medicines because they feel poorly rather than better as they expect. And many of the drugs may interact to create adverse effects that may impair prognosis and outcomes. Beyond this, there are issues with health literacy, so that many patients, even given a prescription, are unable to read or understand the instructions for taking medications. Many of our patients have attitudes to taking medication in general that impair their ability to adhere to instructions that we give them. Social and family supports are important, since particularly for those patients with cognitive impairment, who are nearly a third of our patients, elderly patients with heart failure, if there is no infrastructure to help them take their medications, there's just simply too complex a burden to manage. And the overlay of psychiatric illness, particularly depression and anxiety, may also influence the rate of medication adherence in this population. And identifying and managing all of these factors may be important to improving outcomes in our population and enhancing the ability of patients to care for themselves. If we move from medication adherence to dietary adherence, the key issue here is sodium restriction. We know that dietary intake of sodium has a lot to do with the rate of heart failure hospitalization in patients with chronic heart failure, because intake of sodium is associated with higher rates of heart failure decompensation. The American Heart Association guidelines for not just heart failure patients, but for the population in general, recommend that sodium be restricted to 1.5 grams per day. And the Institute of Medicine has suggested that that limit might be as high as 2 to 3 milligrams per day, or an average of 2.3 grams per day. But if we take the NHANES data looking at utilization of sodium in the general population, about 90% of men and women, at least in the United States, consume more than what the Institute of Medicine has defined as the tolerable upper intake limit of sodium. And a fraction of those patients with heart failure also meet those criteria, suggesting that most of our patients are probably in their routine diets consuming far too much salt. 60% of the patients discharged from the hospital in the European Heart Failure Survey recalled being given some dietary advice about sodium restriction, which means that we give the right instructions about 2/3 of the time. But unfortunately, only 38% of those who received instructions actually reported following the advice, so sometimes the information that is delivered is not received or implemented by the patients, and that gap is an important contributor to the burden of morbidity in heart failure. So what are the challenges that patients encounter in adhering to the dietary prescription to restrict their sodium intake? The first is that patients don't understand which foods contain sodium and salt. Part of this is that most of our patients don't read labels, and when they do, they don't understand exactly how to integrate that information into designing a dietary plan. Many patients, even if they would like to adhere to the instructions, rely on prepared foods, and those prepared foods, which are canned or instant preparations, may have high content of sodium that simply makes it hard for patients to adhere to the instructions. Patients who want to adhere to the heart failure restriction may have trouble doing it because they also have restrictions for diabetes or chronic kidney disease that also make it harder to find appropriate dietary choices. 2 out of 3 of our patients are trying to follow 2 or more diets. The cost and availability of low-sodium alternatives may vary, and particularly for patients who have restricted financial means, access to low-sodium diets may be challenging. And for patients who have ethnic or culturally specific diets, managing a low-sodium diet when instructions are not specific to the diet that they take may be challenging to follow. With regard to adherence, the third component is really adherence to scheduled follow-up with medical providers. We have a lot of data now, some from the Optimize data set and the Get With the Guidelines data set, that suggests that following heart failure admission, early post-discharge follow-up is an important predictor of outcomes. Those patients who are followed up early tend to do better than those who are followed up late, presumably because recurrent congestion happens frequently in that early post-discharge interval. Hospitals in the lowest quartile of early post-discharge follow-up tend to have the worst outcomes with regard to 30-day readmission rates and readmission rates over the longer term. In general, we have gotten better recognizing this data at scheduling our patients for follow-up early after hospital discharge. About 60% of patients in the most recent surveys, compared to maybe 40% earlier on, are given a follow-up appointment within 7 days, and a smaller fraction are given appointments later out, beyond 14 days, for example. However, scheduled follow-up doesn't correlate very well with attended follow-up, and the trends in actual follow-up are somewhat disappointing, with roughly 30% of our patients actually making that early post-discharge follow-up at less than 7 days after admission, despite about twice that many being scheduled for those follow-up appointments. So keeping those follow-up appointments is an important component of succeeding with heart failure management. And we need to think through why it is that patients don't keep those appointments. Some of it may have to do with their confusion around when they're scheduling, transportation issues, cost issues, or other barriers to care, including lack of social supports or family supports. A next component of self-care for heart failure is really the ability to self-monitor. Patients must monitor their condition over time, recognize worsening symptoms for what they are, report them to the clinicians responsible for their care, and then implement the appropriate interventions to correct those problems. They then need to reevaluate themselves to see that the symptoms are improved, and then recontact providers if the symptoms are not improving. And all those components of self-management in that feedback loop have to be met in order for successful outcomes to happen. In most of our patients with heart failure, this means daily weight monitoring. Unfortunately, fewer than half of our heart failure patients actually report weighing themselves on a daily basis, and a smaller fraction of those actually understand what weight changes are meaningful or require reporting to their clinicians. Most of our patients don't recognize the typical symptoms of worsening disease until it is very late, and the later that symptom recognition occurs, the harder it is to avert the inevitable hospitalization that happens in our heart failure populations. So building a paradigm for self-monitoring is a critical aspect of self-management for our heart failure patients. As I mentioned, the key aspect of self-monitoring, at least in the present mode, is weight monitoring, since in the short term at least, rapid changes in weight are typically a marker of worsening fluid retention or congestion. We typically give our patients guidance to look for weight gain of 2 to 3 pounds in 2 to 3 days is too much, or more than 5 pounds in a week is too much. The sensitivity of these changes, however, for detecting heart failure decompensation is not that high when it's been studied systematically. The specificity is pretty good, however, so that the false positive rate of a rapid weight gain for detecting fluid retention is not very high. Part of the problem with weight monitoring is that changes in body weight don't correlate very well with changes in filling pressure, which are really the target of therapy in heart failure. And many patients entering the hospital with heart failure decompensation, even though they have measurable rises in filling pressure consistent with congestion, have little or no change in weight. On average, patients gain about 2 pounds before coming into hospital. So particularly as patients get farther from the index hospitalization, changes in weight are difficult to use to monitor worsening congestion and may be confounded by changes in body weight that are impacted by dietary intake of calories or other conditions. If we then think about what strategies we as clinicians can apply to help patients care for themselves, I think there are a few pointers that we can provide. The first is that it's not enough to deliver knowledge or information to the patients. We need to give them the skills to utilize that information to manage themselves. This means not simply telling them to read labels, but providing them with guidance about how to read a food label. Not simply telling them to monitor for worsening symptoms, but providing them with a framework for self-monitoring, which symptoms to recognize, what to do when they occur, and to provide them with a concrete emergency plan of action so that when there is a problem, they know exactly how to intervene. Instructions need to be individualized and very specific for individual patients. Not every patient will respond to the same treatment framework. Sometimes it's important to utilize the teach-back method to ensure that the information delivered or the skills that are being taught are actually being received by the patients. There are a number of motivational techniques for behavioral change that have shown efficacy in other chronic disease management paradigms, and those same techniques, such as motivational interviewing, may be useful in helping our heart failure patients to enlist in their self-care. We are not the only people typically involved as heart failure specialists in the care of our patients. In most cases, care is provided in collaboration with primary physicians, nurses, and home caregivers, and building the team framework for delivering a consistent message to patients may help them promote their own self-management. Systems of care, including structured heart failure disease management programs, are important, as is collaboration with allied health providers, social workers, nutrition, psychiatry, and other palliative care specialists, as well as pharmacists. A key initial component in delivering a successful self-care program is identifying the barriers for the individual patient and implementing a successful self-care paradigm. Some of those barriers we've mentioned and include overlay of psychiatric illness, including depression and anxiety. The burden of comorbidities is important to recognize and manage, since it complicates, as we said, in adherence to medication and dietary guidance. Comorbid medical illness may also confound the ability of patients to interpret symptoms correctly, since shortness of breath, which is the paradigmatic symptom in heart failure, may be a symptom not only of heart failure but also of pulmonary disease, anemia, and other conditions. Health literacy is a major issue in many of our patients, and if we don't recognize low health literacy, it will be difficult for us to effectively treat our patients. Sleep disturbance is an unrecognized and important contributor to many problems in heart failure, since patients who have poor sleep have difficulties with attention and self-care. And cognitive dysfunction has emerged as an important contributor to non-adherence to various aspects of heart failure self-care in recent studies, particularly amongst the population that is elderly. And these patients may require special frameworks for longitudinal heart failure management. This recognition of cognitive impairment, which may affect as many as 1 in 4 of our elderly heart failure patients, has made the case for screening routinely for cognitive impairment. In one study that has been done looking at the impact of cognitive impairment amongst hospitalized heart failure patients on 30-day outcomes after heart failure hospitalization, those patients with the highest degree of cognitive impairment had roughly twofold the rate of readmission at 30 days relative to those with low likelihood of cognitive impairment. Those patients with significant cognitive impairment may need more engagement of their family members or social supports to enhance their self-care, or at the extremes may require institutionalization or skilled nursing support in order to self-manage more effectively. Prior to hospital discharge, it's critically important that we educate our patients regarding appropriate self-care behaviors. It is interesting that in one study done at the University of Michigan, that a single 1-hour conversation with a specialty heart failure nurse had dramatic impact on longitudinal heart failure outcomes relative to routine heart failure care. Simple messages about lifestyle: what should your diet be? What should the activity level be? What is the appropriate schedule of medications, the strategy for adherence, and how should the medicines be titrated? When exactly are the patients to follow up and with whom? How should self-evaluation occur? What is the strategy for weight monitoring? How frequently should it occur? When should it occur? What are the warning signs of worsening heart failure? And what is the rescue plan that should be implemented when heart failure happens? Discharge instructions must be written, since patients may not recall a conversation that happens briefly in the hospital. The rescue plan is the key strategy that is important for our patients, since if patients recognize symptoms but don't know how to act, then they're unlikely to be able to improve outcomes. The key elements of a rescue plan are to define the critical warning signs that must provoke action, make sure that patients recognize these signs, emphasize the importance of early treatment, not delayed therapy. Many of our patients will recognize the symptoms and ignore them for a period of time until they become very severe, since they don't want to bother their providers or it's inconvenient to come to hospital. And then patients must know when those warning signs are recognized, exactly who to contact, whether they should make changes in medicines on their own or whether they should wait for further instructions, and whether they should present in the clinic for evaluation and what circumstances should prompt more urgent evaluation in an emergency setting. Longitudinal heart failure management is largely nurse-based management and requires a tight feedback loop of communication between the patient and the provider. The patient will have some recognized symptom, transmit that information to the provider, who then must generate an action plan that is then delivered back to the patient. The patient should implement that intervention, reassess their condition, and then contact the provider if the symptoms persist. If that feedback loop fails at any point along the way, then home care or remote care may not work, and there may be a need for in-clinic evaluation. In most cases of remote monitoring, there is some component of this feedback that doesn't happen, particularly if there's delay between receipt of the information that the patient is not doing well and communicating an action plan back to the patient. A hospitalization or an adverse event may occur. And so we need to create structures of care for our heart failure patients that allow them to efficiently contact providers and receive an action plan and then respond appropriately to worsening outcomes. And it is clear that when we develop effective multidisciplinary disease management paradigms that include pre-discharge education to enhance self-care, nurse-led coordination of care and post-discharge surveillance, and clear immediate access to providers, mid-level or physician with specialty expertise in heart failure, we are able to dramatically influence outcomes, including mortality by about 25%, heart failure readmission by about 25%, and overall hospitalizations, perhaps because of synergies with management of heart failure and comorbidity, by about 20%. This can be done in a cost-saving fashion or a cost-neutral fashion. And although it's not entirely clear exactly what are the elements in the special sauce of heart failure longitudinal management that are effective, some of the components we've discussed are clearly critical elements. Additional important strategies to help our patients manage themselves better are to talk about fluid restriction in selected patients. Adding fluid restriction or layering fluid restriction on top of sodium restriction and all the other guidance we provide to our patients is sometimes overwhelming. I tend to restrict fluid restriction guidance only to those patients who have refractory symptoms and hyponatremia, since routine fluid restriction guidance simply enhances thirst and then impacts on non-adherence. Moderation of alcohol intake is important for most of our patients with heart failure, particularly those with reduced ejection fraction. Abstinence is recommended especially for those who have alcoholic cardiomyopathy or presumed cardiomyopathy of alcoholism. Counseling regarding smoking cessation is important for all of our patients, but no less for heart failure patients. Routine influenza and pneumonia vaccination have shown to improve outcomes in this population. And an important and often overlooked feature is the need to counsel our patients regarding non-prescription medications, particularly the use of over-the-counter preparations such as non-steroidal anti-inflammatory drugs, which may exacerbate fluid retention in heart failure, and the use of herbal medications, which our patients often don't consider medications at all, and sometimes layer on in the presumption that they're helpful without any potential cost, but may interact with many of the medicines we're prescribing. A final component is really the guidance about exercise that we provide to our patients, which we believe has important beneficial effects in heart failure. The general goal of exercise in heart failure is to get our patients to the point where they can exercise 30 minutes at moderate intensity for most days of the week with this appropriate warm-up and cool down. Some of our elderly patients may not be able to manage that level of sustained exercise, and for those who can't do 30 minutes at a stretch, perhaps breaking up that exercise into 2 to 3 segments so that they can get the 30 minutes cumulatively over the day may be a better strategy. Those patients who aren't quite sure how to generate an exercise program that's safe may benefit from cardiac rehabilitation for supervised exercise training that can then be adapted for the home setting, as was done in the heart failure action trial. But overall, for most of our patients, some exercise and any form of exercise is better than doing nothing at all. Heart failure self-management will evolve because heart failure management is evolving with time. Weight monitoring has many limitations that we've discussed, and weight changes correlate poorly with changes in filling pressure that are the real target of our therapy. There are now commercially available devices that can be implanted in patients who have particularly refractory disease for longitudinal monitoring remotely of filling pressures. These filling pressures may then be used to guide therapy in that same feedback loop that we've discussed around weight. And it's been shown that use of these implantable hemodynamic monitors in selected patients with heart failure can enhance heart failure management and improve outcomes, including the cumulative burden of heart failure hospitalization over time by as much as 30%. Next generation implantable hemodynamic monitors will allow patients to view their own pressures and perhaps to titrate diuretics on sliding scales that are provided by their clinicians, such that they can begin to self-manage heart failure according to filling pressure, much in the way that diabetes patients self-manage diabetes in response to glucose monitoring. Trials of this approach to heart failure longitudinal management are underway, and while this may not be a strategy that is scalable or relevant for all of our patients with heart failure, it may be an exciting opportunity for enhancing home management of patients with heart failure who are particularly refractory to standard approaches. A final comment about self-management is that not only is self-management different for different patients, but it's different for an individual patient as the disease changes. We know that heart failure is punctuated by periods of decompensation, and that after these periods of decompensations, patients have recovery to a baseline that is not quite what they were before. And there is a steady trajectory of decline in heart failure as the disease progresses. Functional capacity may reach a point in heart failure as it approaches the end stage where it is necessary to consider salvage therapies, including mechanical circulatory support and transplantation. The vast majority of our patients will not be eligible for these therapies, and in that population, it's important that as the disease advances, we are amplifying the supports for palliative interventions to manage symptoms. As palliative care becomes the dominant feature of our heart failure management, the goals of self-care in heart failure may change. The need for adherence to sodium restriction and fluid restriction may change, as may be the action plans that we recommend that patients implement when symptom exacerbation occurs. So it's important to understand where patients are in the trajectory of their illness, because the goals and priorities may change, and so too may the instructions we provide to our patients for managing their disease. So to conclude, it's important to remember that most of our heart failure patients spend most of their time outside the view of providers, that therefore strategies to promote self-management and self-care are essential. The key components of this strategy include adherence to medications, dietary guidance, and the longitudinal pattern of follow-up that we prescribe. Self-monitoring of patients and a strategy for doing this, including symptom recognition, what to do when symptoms occur, and how to intervene, is important. Lifestyle modification is important for all patients, but no less patients with heart failure. As you implement strategies for heart failure disease management, be mindful of the barriers to implementation of your instructions, including the burden of comorbidities, including psychiatric illness, possible underlying cognitive dysfunction, and the cost of the various interventions you're recommending. Provide longitudinal access to specialty providers in a structured heart failure disease management framework, since that is the one intervention that has been shown repetitively to improve outcomes in this population. And remember that strategies for self-management may need to be adapted in response to changing goals of care for our patients. Thank you very much for your attention, and good luck.